Good afternoon, everyone. My name is Maya Luria, and I'm with TMC for Seniors. And today I have Dr. Robert Berens here with me. Dr. Berens is with TMC's Integrative Pain Center, and he is actually a board-certified anesthesiologist and pain management specialist. He has more than 25 years worth of experience in practicing interventional pain management, and he served as the medical director over at the Pain Center since 2004. So welcome, Dr. Berens.
Well, thank you. Glad to be with you.
Yeah, and today I know you're going to be discussing with us about chronic pain and alternative treatments. So we'll go ahead and let you get started.
Okay, great. Welcome, everyone. I'm glad you can all join us. We are going to discuss today essentially the aging spine and alternative treatments. So as an overview, we'll discuss the normal spine, age-related changes, spine symptoms, the causes of spine changes, the facet joint interventions, arthritis and treatments, the options for radiofrequency ablation type therapies, diagnoses of spinal stenosis, disc herniations, posture changes, scoliosis, and how to slow this aging process, which is challenging. So on this view, we have the lateral side, which is the side view of the spine from the cervical, thoracic, lumbar, and sacral area. The direct view looking at the back would actually look like a vertical line without the S-shaped curve. This is a normal S-shaped curve that we should see. And as the nerves exit at each level, they produce branches, multiple branches into millions of fine nerves that create our motor function and sensory function throughout the body. Going forward, the changes that we see as we age involve majority of bone and disc changes, and a normal disc might look like these here. As the discs lose separation, we also lose height, unfortunately, and we also see changes in the bone. The bone tends to respond to gravitational pressure, and if the disc is not adequate or doing its job, we'll see changes in the shape of the bone as we age. These nerve roots could be compromised as well if these discs do not provide adequate separation between the bone structure. That would give us nerve symptoms radiating from the level of the nerve root and possibly creating sensory or motor function changes. So the disc itself is made up of the annulus, the outside fibrous portion, and the nucleus, which is the softer portion, creating this shock absorber type device. And we've got mostly 24 of these in our spine. And the levels, each of the levels of the vertebral body, this is the vertebral body here, and its attachment points above and below are these facet joints, which allow us to flex forward and backward. So the changes that we might see with aging include disc degeneration, which would be desiccation or drying out of those discs to a certain extent, as well as compromise of the height of the disc. Those facet joints at each level can have arthritic changes, which would produce sometimes discomfort. Our goal is to maintain that range of motion and function at each of these levels. Unfortunately, as we have discomfort, also we limit our function, and we may decrease muscle mass as well as we age, and the bone density also may decrease. Flexibility and range of motion would be compromised if we are not able to maintain that function in the joints at each level. And as I mentioned, height reduction. Our posture also may change due to the changes in the disc, bone structure, and the joints. Our ability to walk and participate in more challenging movements would be also compromised. And we also find as we get older, our movements slow, and we also may lose balance and coordination due to some of these changes. The disc symptoms that we see at all the levels include these degenerative disc changes that you see on the right, which would be just a desiccation or drying out or possible flattening from our normal disc. We also may see a slight bulging at different levels. This bulging disc may not produce any actual symptoms. Oftentimes the disc that bulges does not actually compromise the nerve root. If a disc herniates further or protrudes further, it might actually impact the exiting nerve root at that level. The more severe degenerative change of the disc would cause thinning, and now we might see changes in the bone structure itself due to the impact of pressure from above or below and the effect of the loss of disc space. These changes can lead to bone spurring, or as it's called, osteophytes, bone spurs that might move out laterally from the center of the spine and at times could compromise nerve access as well. Some of these aspects can produce chronic pain. It is a challenge at times to deal with the degenerative disc changes and also to relieve this pain. Most of the time we are finding exercise and range of motion therapies are the most effective at allowing us to age more gracefully and maintain function. Not uncommon is to see fairly severe changes without any symptoms whatsoever, and that is very common in a variety of our patient population. So after the age of 20s, we'll see disc degeneration, which can occur naturally. Some of the risk factors that escalate disc deterioration go along with history of tobacco use due to carbon monoxide or nicotine exposure itself. Obesity, when our body mass index may be over 25. As that increases, we also have increased gravitational pressure on these discs. The genetic aspects are variable, and we really haven't quantified those, but it's a fairly low percentage in most of our patients. Trauma at specific areas may cause problems, and we would see an injury, but oftentimes when we're discussing disc degeneration, it's occurring fairly broad areas. Often the lumbar distribution is the most common to have pain and changes along with the cervical area, because both of those areas have the most movement. So we are moving forward. We've got discussion of the facet joints, as we talked about before. In motion, these facet joints will maintain function and flexibility quite well. The muscles that attach, as well as the ligaments, should allow function without pain as we age. Unfortunately, not everyone maintains that flexibility through exercise, and so we strongly support physical therapy and learning to do these exercises daily, along with cardiovascular type exercise as well. So these facet joints support the spine. They allow us to maintain flexibility. They are true joints with cartilaginous barriers and fluid, which is the synovial fluid that maintains the smooth function of the joint. There are 3 joint complexes at each level, so you see that the disc is providing stability at the front, and we have 2 facet joints at each level on the back that support it. Any arthritic changes in these facet joints would contribute to aspects of our pain. There are something in the order of 20 different types of contributions to the spine in terms of producing pain at any level. And we are constantly trying to find new ways to provide relief and function without serious intervention. Here's a picture of more arthritic changes at each of these joints. These joint surfaces can change, and they change most commonly when we see these kind of disc degeneration aspects. This may compromise the exiting nerve root, as you see here, and lead to compression of the nerve and oftentimes pain along that nerve root into one of our extremities. This also will limit our range of motion and progress to a point that it becomes difficult for treatment. If we are losing nerve function, oftentimes surgery is a good option, and stability of the spine may need to be reproduced through surgical intervention with hardware, or as fusion might be discussed. So initially we use physical therapy, a daily exercise regimen. Options that we'll discuss in a little bit will also include interfering with the nerve function at this joint, because we are unable to replace these joints as we might in other parts of the body. So the nerve that serves this joint can be interfered with by radiofrequency interventions, and that is the radiofrequency ablation therapy. So surgical intervention is considered as we might lose function or the nerve is compromised. Radiofrequency treatment essentially would send a radiofrequency signal to the medial branch, which is the nerve that serves the facet joint. And by sending this radiofrequency signal, we can ablate that nerve function, and through temperature increase with the radiofrequency, we can ablate the nerve to a point where it would possibly not send abnormal signals to the brain for prolonged periods of time. Oftentimes we see as much as a year or longer relief without further intervention. Structural problems within the spine may at times need surgery if the spine is unstable or moving, in which case we might see nerve compromise. Without nerve compromise and without structural instability, we would look for other means to control symptoms without surgical intervention. So we will improve range of motion through physical therapy. Use of analgesics is an option, but we would like to reduce them, and radiofrequency options allow us to get there often. And by going this direction, we also can improve your quality of life and also shorten the time in which it takes to receive that general relief. Cervical spine pain is similar to lumbar in the sense that range of motion of these levels is important to evaluate. And if we are able to see that the cord is intact, that would be this yellow structure. If the discs are not providing stability or adequate support, and the facet joints also may be involved in terms of that compromise, other options could be considered, much like the lumbar spine. Things that we see much often with the cervical spine, it may involve numbness and tingling, and the facet joint arthritic changes as well. If nerve function or blood flow is compromised, surgical intervention may be needed. So physical therapy, range of motion exercises are important. Plain x-rays may be helpful to assess the degree of arthritic and degenerative changes. And again, surgical options could be considered as a last resort. In the cervical spine, if we have significant compromise of the spinal canal, we would see worsening pain. It may also be function loss in our legs or arms, depending upon the degree of narrowing. Again, an MRI would provide that information for us, as well as a CT scan if you're unable to have an MRI. For our treatment options, initially we would start with analgesics and anti-inflammatories. Physical therapy is a mainstay to improve function, and the option for spinal injection therapies, which may improve some of the inflammatory processes that escalate, and especially in an acute setting. Again, if we are losing function or this is escalating, we would consider the surgical options. Disc herniations are actually a significant problem and provide many patients which have more acute loss of function more so, and symptoms increase in order of weeks or months. They are common and oftentimes can compromise a exiting nerve. Some patients who have been put into MRIs for diagnostic purposes in large numbers, these studies have been done just to see what is normal. We often see disc herniations that do not press upon nerves, and so it is not uncommon to see disc protrusions that are not affecting the patient and don't follow the nerve distribution that they are complaining of. Oftentimes this can occur without trauma, but patients do relate a fall or an injury many times to the onset of symptoms. Injection therapies can offer some relief for this, and in the acute phase can be quite helpful, along with physical therapy. Pain in the limbs is also indicative of nerve compromise. Early, we start with rest. Ice and heat can be useful after the acute phase. The analgesics, the anti-inflammatories, muscle relaxants, also an option. Physical therapy and spine exercises may improve symptoms as well. The spine injections can allow all of these to improve at a faster pace at times, especially with acute disc pain. And if necessary and we are losing function, we would consider surgical options. Postural changes that occur as we age include changes that affect the curvature of the spine, and each of these designate a different type of problem. The normal posture is where we might see the ears over the hips in this patient. Forward leaning is often a curvature of the upper thoracic spine that is called thoracic kyphosis, and if it worsens, we can see lumbar involvement with lower lumbar pain and upper back and neck pain from changing the alignment of the spine. Lumbar lordosis, again, is a opposite, where we are seeing a hypercurvature of the spine in posterior motion of the lumbar spine. And we've seen patients as well with sway back, which is similar, but adjustment for the pain. Oftentimes we see patients trying to ambulate or walk without support, and they're somewhat unstable at times when the spine is not providing direct support from the head through the lower legs. So we try and improve this with physical therapy again. We often see that obesity, pregnancy, osteoporosis, or bone density changes can make this worse. And our goal is to support the spine and provide as much improvement as we can with the available bone structure that we have. Scoliosis, as we talked about, may advance as we age. It is often found to mild degrees in younger people without even knowing about it at times. More severe scoliosis is obviously very visible, and the structural pain can increase some of these pain levels at the lumbar spine or thoracic levels involving those same facet joints or discs, and may revolve around some of the interventions we discussed, including facet treatments and physical therapy. So range of motion exercises, the radiofrequency option, again, is there available for some of these problems. Smoking cessation keeps working its way in there, and as well as weight reduction and improving general fitness. Spondylolisthesis is essentially a step off of the vertebral body in which it's losing that normal alignment, and some people call that a slip vertebrae. These discs may also have degenerative changes. Unfortunately, if that is advancing, we can see compromise of the spinal canal, in which we would create pain and electrical signals into the lower extremities. If there's nerve compression and we're seeing increasing nerve compromise, then all of the same options are available, but we would also lean toward surgical intervention to support that defect. So again, reviewing, we've got bone spurs, osteophytes, canal narrowing or stenosis, FACET changes or arthritic changes of the spine. And if we have diminished arm or leg function or scoliosis, each of these can be found in the same patient or individually as single problems, and we would address them as needed. So the options to slow the progression that we call aging is essentially to maintain that normal muscle function and tone as well as ligament strength through appropriate exercises. And many of these exercises can be found on YouTube, even by typing in lumbar spine exercises. There are quite a few physical therapists there to give us some guidance. If needed, physical therapy with direct visits is a great idea for some of our patients, as well as working on nutrition and weight control and avoid smoking exposure. Other questions that often get asked are use of alternative therapies such as yoga, Pilates, Tai Chi, water exercise, which is excellent, acupuncture, chiropractic, massage, all which may provide symptomatic relief. And as far as maintaining range of motion, these exercise options are great. Seeking options with us at the pain interventions clinic would be great if you have not found relief so far, and especially if we can provide intervention for you related to some of these diagnoses that were mentioned here. We have quite a lot of other options in terms of integrative approaches, but we use many modalities to offer treatment. So that pretty much covers it. Nice picture of the Sabino Canyon there. And we'll take questions if anybody is out there. Maya, I cannot hear you.
Sorry about that. So one of the questions that we received was about your posture and ways that you might be able to improve your posture. Are there any specific exercises that somebody might want to do in order to maintain some good posture?
So yes, the answer is yes. There are many ways to work on posture reminder kind of activities. To change a curvature of the spine is difficult, but we can build up muscle and improve function through physical therapy exercises. And there's some great ones out there, but also seeing a physical therapist can be very effective in the early stages. If they need reminders, there's also postural support devices, which a lot of my patients go to Amazon and purchase these simple devices, but there's many of them that are fairly easy to use, and they're just reminders so that even as I'm sitting here, I'm leaning forward. But many of us should try and keep our ears over our hips and stay in a upright posture. If we're talking about a pathology of the spine and significant scoliosis, it's difficult to make changes, but it's not difficult to maintain muscle support and muscle tone through these exercises.
Oh, great. And what about, we had a question come in asking about an anti-inflammatory diet. Would that be helpful?
So the anti-inflammatory diets are the rage right now. There are many studies out there showing patient satisfaction with staying on curcumin and black pepper and various different additives to the diet. We have not seen long-term studies showing that it's changing outcome, but we have seen patient satisfaction scores go up. And so use of analgesics and anti-inflammatories also do that. We have not seen head-to-head comparisons, but there are quite a few natural remedies that you can look at online that are purporting to give patients relief. And it's not universal, but we're seeing positive reports back from the patients.
Okay. And are there any foods that you should avoid? I don't know if there would be or not, I don't know if it was referring to that specific diet or whether it was just in general that might be helpful.
So there are diets out there, without getting into the specific foods. There are anti-inflammatory diets that are being mentioned in the literature right now, especially in the nutritional literature, for different reasons. So not necessarily for the spine, but lots of people are starting these anti-inflammatory diets and removing certain foods from their diet and adding others. I would like to say that I've got a big following of patients that have resolved all their spine problems from doing so, but I can't say that. But we do have a lot of patients following them. Yeah.
Okay. And can you tell us a little bit about, if somebody needed to have injection therapy done, what does that look like? What's that time frame? I assume it may be different for everybody, but I don't know if there's an average or.
For the time required, is that the question?
Well, like how many times would you need to come in for something like that in order to start getting some relief?
Well, if somebody has acute symptoms that have occurred in the previous weeks and not years, those are going to be easier to change. If we're dealing with chronic degenerative diffuse spine changes, that's going to take a little bit longer. So what we see is the more acute inflammatory changes, we can make quicker responses with over a matter of 1 or 2 visits. And oftentimes it may only be 2, 3, or 4 visits, which we might be able to focus on the areas of maximal pain in which the patients are coming in. Sometimes people that have diffuse spine pain, a little bit more challenging, we're trying to focus on the area that are the most severe.
Very good. Now, can you just let us know a little bit about the Integrative Pain Center and what somebody needs to do? I'm going to go ahead and put the phone number up on the screen for everybody for an appointment. Looks like we've got the phone number is 324-2080. So people would just call if they've got a need, and you'll help them through, or the staff will help them with the referral process. Is that correct?
Correct. We do require a referral into our center. So as patients call in, it's a fairly easy process, and we would assist them. You're still there?
Yes.
Well, hang on a second. We obviously timed out here. Ran into our end of day issues.
Okay.
We'll get us back on here in a second.
Okay. I can see you and hear you just fine.
You can still see me?
I can, yeah.
Okay. All right. Okay, there we are.
Yes.
So it's a fairly easy process, and the scheduling people run you through that. It just involves filling out the appropriate forms to get patients in the front door, but it's not difficult.
Okay. So again, that number is 520-324-2080. That is all the questions I have for today, Dr. Berens. I want to thank you so much for being here and presenting for us. I really appreciate it.
Well, thank you. And hopefully we've helped some people and guide them through this process.
Absolutely. Please watch for us next week. We do have another part of our pain series with the TMC Integrative Pain Center. Dr. Abraham will be speaking about using pain relievers from aspirin to opiates. And that will be on Tuesday, November 17th at 4 p.m. So we look forward to seeing you all back then. Thank you.
Great. Thank you again.